I'd like to welcome all of you along to our first webinar on heart failure, recognizing the signs and symptoms. So it's great that most of you have come along and spending your lunchtime learning a little bit more around heart failure. Just want to do a little bit of housekeeping, and as you'll have seen, we have begun to record the session, and one of the common questions within the chat is, will the recording be shared afterwards, and will the slides be shared afterwards? And I'm happy to confirm that both of those assumptions are correct. If you've got any problems with the recording, if you could please let myself or Yo-Yo know. As many of you have already done, if just a little bit of housekeeping, if you could keep your microphone muted. Very happy for you to keep your video on. I've done some of these presentations before, and it's always strange presenting to blank screens. So happy for you to have your video on, but keep your microphone off just so that there's no distractions. If you have any questions, please use the chat function. We'll have questions at the end after the presentations from Jack and Ahmet. And we'd also like you to use the chat for you to present any ideas for future webinars. We plan on doing another 2 to 3 webinars over the next 9 months around heart failure. So if you've got any specific topics that you would like to be covered, use the chat function as well to put in those ideas. And if you've got any problems throughout the webinar, if you want to contact Yo-Yo, and Yo-Yo's email address is on the slide there. Next slide, please, Yo-Yo. So I'm delighted to go through our agenda for today. So we've got 2 fantastic speakers in Jack Lyons from North East and North Cumbria Integrated Care Board, and Jack is the project delivery lead for cardiovascular disease, and Jack's going to be going through heart failure across North East and North Cumbria, setting the scene. And then we're delighted to have Professor Ahmet Fouet, who has a number of letters after his name, which is fantastic. Ahmet's been a fantastic friend to Health Innovation North East North Cumbria over many years, and even when we were formerly the Academic Health Science Network. So it's great to have yourself here, Ahmet, as well, who's going to be looking at the overview of heart failure burden, diagnosis and management. And then if we have time at the end, we'll go through any questions within the chat, and we'd have a wider discussion on what we can focus on over the coming months, as this is our first webinar on heart failure. So I'd like to hand over to Jack now to take us through a bit of a background of North East North Cumbria heart failure data. Thank you, Jack.
Great, thanks, Mark. So hi, everybody. My name is Jack, as Mark's introduced. I work in North East North Cumbria ICB, mainly covering cardiovascular disease, but linking with other long-term condition colleagues as well. Historically done quite a bit of work on prevention side of things in cardiovascular disease, so looking at how we case find and optimize the ABC conditions, so that's atrial fibrillation, hypertension and lipids. But more recently started to look at cardiovascular disease further along the pathway, such as cardiac rehab and heart failure, which we're discussing today. So I'm just going to cover a little bit of data within the NENC, so North East North Cumbria, to introduce us to, I guess, the scale of heart failure in our region, and then just pick up a little bit on where heart failure kind of sits in the ICB and related work to that. So as Mark said, I'm happy to pick up any questions towards the end of the session as well. So I think we're working with the slides, yes. So I'm not going to go into massive detail here. We could have a few different slides on the kind of the overall cardiovascular disease picture in NENC, but just as a kind of high level overview, as many of you probably know, as a region, we do have poorer health outcomes and greater health inequalities compared to other areas in England. The graph might be quite small here, but we usually balance between us and the Northwest for the highest CVD mortality in the country. So poor health outcomes, as I mentioned, are health inequalities as well. So cardiovascular disease particularly is one of the largest contributors to health inequalities in our region and causing that gap in life expectancy. So between the most deprived and the least deprived areas. So the second graph down here, you can see that people which live within decile, well, on this actually it's quintile 1 from the most deprived areas, have greater CVD mortality than the more least deprived areas, so quintile 5. And the bottom graph underneath that as well, that might be a little bit small, but you can see that some of our areas such as Middlesbrough, Hartlepool, where we have greater health inequalities across our region, have the highest CVD mortality as well. And generally, we find that, you know, these rising rates of CVD and mortality and poorer health outcomes are driven by lifestyle choice is a big one, but socioeconomic factors and our access to healthcare services as well. As I say, we could go into more detail to that, but I'm going to go straight into some of the heart failure specific stuff today, being relevant to this webinar. So I'm going to present a few different data sources here, and I will mention them as I go through. Now, this first slide overall is from the NICOR data set, which is actually behind in terms of time scales. So this is data from 23-24, which might question how much that can tell you. But this, in terms of a national data audit, is the most latest data we have access to for this at the moment. So to give you a bit of an idea of kind of heart failure admissions and the trends over time, we are seeing a bit of an increase, particularly since the pandemic in 2019. This is hospital episode statistics, my understanding, and we are going on the increase, which is obviously that we don't want to see for our admissions here. And looking into a bit more of a heat map view on the heart failure admissions, you can see on the graph here that the darker shaded areas are where we have higher heart failure admissions, which is generally within kind of the Midlands areas that we're seeing here. We are obviously a little bit darker than probably some of the more central southern areas like London, etc. But generally we can see that the Midlands have come in the highest admissions, and you've got the actual numbers on the side here. The rate across the country for heart failure admissions varies from 41 per 100,000 of population, which is down in Cornwall, which might not come as a surprise, and the Isle of Sicily for up to, that's 177 per 100,000. Sorry, in Dorset, sorry, actually. And that's from NICOR data set as well. Now, moving on to some kind of regional prevalence of heart failure here. This is from the CVD Prevent data audit, and this is looking at from a regional overview, and we actually categorize on this as Northeast and Yorkshire. So bear in mind, this is including Yorkshire, not just the Northeast. And we have a 1.51% prevalence of heart failure, which is in line with the Northwest. As I was just saying before, we have similar CVD mortality rates. But the Southwest, according to this data, has a slightly higher prevalence, but it comes down to case finding, of course, as well, on the case finding activity, which is happening for heart failure. It would be interesting if we compared estimated prevalence compared to the actual prevalence. But in terms of the data sources that I'm aware of, we do have an overall estimated prevalence for the full country for heart failure, but it doesn't go down to regional levels such as this. But if anybody is aware of that data source, do please let me know, because it's something that'd be really interesting to look at. Getting a bit more to specifics for NENC as our region, you can see that the prevalence of heart failure across what I generally call them our sub-ICB areas. You can see that Northumberland has the highest prevalence of heart failure at 1.9%, and Newcastle the lowest. Newcastle maybe doesn't come as a surprise when you think maybe about the demographic. In Newcastle, in terms of age ranges, quite a mix of age ranges and younger populations potentially. But Northumberland highest, along with County Durham, not far behind as well at 1.8. You can see the actual numbers here when you look at the NENC population, which is about 3.2 million. And the number of diagnosed with heart failure is around 48,000, which is about 1.5%, which aligns with the slide which I had up before around North Eastern Yorkshire as well. And this is pulled from primary care systems. Also, we have some colleagues which can pull this for us from NEX. Incidence is obviously an important one when we're talking about prevalence. So incidence in terms of the newly diagnosed cases in the last 12 months. Interesting to see this as a kind of regional sub-ICB breakdown again. You can see that County Durham and Northumberland also had the highest prevalence. You also have the highest incidence. So it comes back to, I guess, case finding here as well. We could think about, right, where is the highest case finding activity across the region? Where are we finding the most cases of heart failure in the last 12 months? You can see Newcastle and Sunderland also at the bottom, as they were on the prevalence slide as well. In terms of if you want to compare that by gender, you can see that males, higher incidence, more cases been found in males than there is females as well. Same data source, we can look at age range, which again, this might not come as a surprise, but generally in our older age ranges, oldest age range being 90 to 99, we're finding the most cases, close to 100 and over as well in terms of age ranges, and 80 to 89. And then you see a bit more of a significant drop off in the younger age ranges as well. And let me just I did skip along a slide there, so let me just make sure that I'm going back. Okay, brilliant. So yes, then we've got a slide here on the percentage of heart failure patients on directed drug as well. This is also pulled from primary care systems at a request from my colleagues. We wanted to look at this. So if you're interested in the actual drugs which have been included in this search, if you can see it, the drug names, which I'm not going to pronounce and try to butcher, are just along the bottom there as well for the drugs which have been included in this search in terms of direct drugs. And you can see that Sunderland has the highest percentage of patients on a direct drug. And interestingly, if we go back to the prevalence, Sunderland was towards the bottom for prevalence as well. And Northumberland has one of the lower percentage of patients on direct drugs, and they had the highest prevalence if we go back to that previous slide as well. So it might just be of interest to look at in terms of actual percentage of patients on directed drugs for heart failure. And then we get into some more kind of secondary care stuff here in relation to heart failure, which is from the NICOR data set, which I had in the initial slides looking at the admissions. As I mentioned, this data is outdated at 23-24, the year there. But what I guess the key thing to highlight here is that there is a bit of variation across our region in some of these indicators and data that we're looking at. So this is looking at the percentage of heart failure patients receiving care in a cardiology ward by hospital. We can see that James Cook is the highest at 95%, and then West Cumberland Hospital down at 17%. So it's quite a significant variation in the numbers there. And I believe there is a national target of 60% for this. So actually, it's just three of our trusts meeting this national ambition. But it's not just our region. I believe that a lot of the country do not meet that national target of 60%. Next slide. So percentage of patients seen by a specialist heart failure team by hospital. So it goes without saying that obviously timely access to a specialist heart failure cardiologist, specialist heart failure nurses will be associated with better care, reduced hospital mortality, and so on. And you can see we've got quite a bit of variation here again with Darlington Memorial Hospital and James Cook at 97% towards the top, West Cumberland and North Tyneside towards the bottom at 39 and 40. So again, it's quite a big variation in the difference there. And the national target for this, I believe, is 90%, which means that it's just two of our trusts achieving that target. But again, I believe not many of the hospitals across the full country meet that national ambition. Another interesting one is around diagnostics. So the percentage of heart failure patients undergoing echocardiography by hospital. Obviously, this is essential for diagnostics of heart failure. And again, variation again, we've got Northumbria and North Tyneside of 49, 50%, up to 99 for James Cook, and Sunderland and Darlington at 98 as well. But again, there's a 90% target ambition in here, but nearly half of the hospitals across the country failed to meet that ambition. It's just, well, we've got about 5 of our hospitals meeting that ambition in the region. And just another heat map here looking at prescription of disease modifying drugs in patients with HFrEF, so heart failure with reduced ejection fraction. This is just highlighting that there is variation seen across the country in the prescription of some of the kind of key drugs such as ACE inhibitors, etc., SGLT2I in patients with HFrEF. So rates varying between 17% right up to 89% in prescription of these. As an ICB, we're around 33% for this. We're in a kind of a lighter area in the shading, where have you got some kind of darker areas right towards the kind of East Coast Midlands area there. So that's all covered on data, and I'm just going to go into a little bit of background in terms of the heart failure within the ICB now. So this year, well, if we're talking financial years, just in the last year just gone, the ICB developed a clinical condition strategic plan, which is basically a high-level plan highlighting how we improve, I guess, patient outcomes, health outcomes in some key conditions. And we've got 5 for adults, which is lung cancer, cardiovascular health, respiratory health, low back pain, anxiety, and depression. And then some of the ones along for children and young people, which I won't go into detail now. But relevant to us is obviously cardiovascular health. And the link is there if people want to have a look at the strategic plan as a full document. And there is other documents tied to that as well, which might be useful. But I guess the aims and ambitions of the strategic plan is to deliver improved care outcomes, tackle the inequalities and variation that we see across our system in healthcare services and outcomes for patients. Prevention is becoming a part of the common narrative, but prevention is becoming much of a bigger thing with the long-term plan, which is just being published, I believe, now today. Prevention, care closer to home, and shift from analog to digital as well, all kind of ties in with this, with the kind of national ambitions on that also. Creating a learning environment. How can we share the learning, which we'll constantly need to do, and we do benefit from that, and prioritize investment in greatest areas of need also. So looking at that variation, where can we improve the best care and outcomes as well? Just briefly, this is a bit of a snapshot of something taken from the clinical condition strategic plan, which is a high level overview of, I guess, what we want to do under cardiovascular health, and it's aligning with prevention. So how we manage the risk factors for cardiovascular disease, such as hypertension, lipids, and so on, case finding for those, but then also diagnostics for things such as heart failure, treatment. So how do we look at our models of care and improve models of care, ways of working, and so on, and rehabilitation to ensure that we do focus on secondary prevention for people that have had a cardiovascular event. So as I said, it's quite high level in the clinical condition strategic plan. We do have more detailed work on this, which the ICB is doing. And I guess aligning to this kind of group, well, this webinar today, sorry, is the non-specialist cardiac work program within the ICB, which includes heart failure, and is, I guess, we're working towards these national priorities, which you'll see on the screen now for heart failure, which is around improving early diagnostics and management of patients with heart disease, early detection and diagnostics for heart failure with increased access to NT-proBNP and echo, heart failure virtual wards, access to heart failure specialists during admission, which was kind of some of the data which we went through earlier, timely access to heart failure specialists and outpatients, as I just mentioned there, and heart failure at home as well. So they're kind of the national priorities which we get from NHS England, which the ICB has to kind of focus some of our work on to try and align with those, whilst considering obviously our local and regional need as well. What are the key needs for our region, which we obviously need to focus on. Cardiac rehab have gotten there as well, because that's included in this program, and heart failure rehab is part of the rehab program as well, which is relevant to this. But yeah, some of the current activity in ICB relevant to this. Heart failure is something that we've just started kind of to look more closely at, to be honest, whilst we've been doing other bits of work the past year. But recently we've established a heart failure group across the system to work with key stakeholders that are involved in heart failure, such as yourselves, or work with you guys to understand, what are the key issues across our region and priorities for heart failure and improvement opportunities. So it's starting to look at the data and using any local intelligence and learning from people like yourselves doing this work on the ground. What are the kind of key areas we need to look at as a region? Work collaboratively with Health Innovation, as we are doing today, to look at how we work together on improving these priorities for heart failure across the region, and also establishing links to Provider Collaborative as well, who are also starting to look at some of this area. So we're just in conversation with how we might link up and join our efforts as well. So I think that's me, but questions slides I'll leave out, because I know we're going to leave questions to the end. So I'll stop there and hand back to Mark for now.
Thanks, Jack. That's really helpful. Some really useful data there. So far, you might have got a little bit lucky. There aren't any questions in the chat, and we did say that we'll leave the questions to the end. I've got one or two questions written down anyway, so you might not get off that fortunate. We'll move straight on then to Professor Amit Fuat. Amit, thank you for joining us. And if you'd like to take control and take us through your slides, thank you.
Oh, I thought I had taken control.
You have. That is moving. If you,
Oh, is it right? But is it
moving.
full screen?
It is, yes.
Oh, okay, right. So obviously I can't see that. So thank you very much. Thanks for the invitation. Ahmed Fuat, I was a GP in Darlington 37 years, retired from my practice a couple of years ago, got bored after 2 months. So I currently help out at my wife's practice, mainly looking at heart failure, but I sit on various committees. So I'm NHS England Heart Failure Expert Advisory Group member, and I'm heart failure and CVD advisor for actually Health Innovation Network East of England. My interest in heart failure is I did my PhD in heart failure on the diagnosis and management, and then went on to set up the country's first one-stop diagnostic clinic using natriuretic peptides in January 2002 with my friend and colleague and mentor, Professor Jerry Murphy, and Vicky Duffy, who was our nurse at the time. That clinic still runs and is run by Yasat Samaraj and his team at Darlington. Now, NICE guidelines are way out of date. They're currently being reviewed, but in my opinion, quite a narrow review. So I make no excuse for talking about the ESC guidelines today, and anyone can access those at www.escardio.org. Now, you'll also see at the top here, PCCS, Primary Care Cardiovascular Society. Any health clinician can join that. It's free to join, and there's lots of brilliant resources, including about heart failure on that. But today I'm sort of going to gallop through diagnosis, touch briefly on management, because what we are going to do is have future webinars that look into management on more detail. But I'm very passionate about heart failure because 1 in 5 of us will get this in our lifetimes. There's over 1 million people living in the UK with heart failure, and it's almost certainly underdiagnosed and often not coded, which I'll touch on later. It still accounts for the biggest proportion of hospitalizations in over 65-year-olds in the UK, and a third of those will be readmitted within 90 days, or around 30%, and 30% will also die. So going into hospital is not a good thing, and we need to be diagnosing it and keeping people out of hospital because it's immensely costly. And I'd really like to make a plea for us to diagnose and manage HFpEF better, which I'm going to talk about in a moment, because those patients yo-yo in and out of hospital and are often not managed by many heart failure teams. I think we're fortunate in Darlington, and certainly that we've always taken them into the service, and I hope they still are. But we are going to see increasing prevalence because the reality is people are living longer and we're keeping them alive after their MIs or coronary events. So what are the causes of heart failure? And I think we need to appreciate this because the causes underpin the range of mechanisms, often acting in synergy, because many patients have more than one of these and may actually then impact on how we manage things. So we know that ischemic heart disease is the biggest cause in the Western world. Up to 2/3 of patients who've had an MI, especially if they've had an ST elevation MI, go on to get heart failure if not treated or managed appropriately. And then you've got things like ventricular arrhythmias, AF, the commonest, amyloidosis is becoming more recognized, severe valvular disease, and inflammatory or autoimmune diseases. And we would count COVID within that because we saw a lot of myocarditis. Poorly managed, late diagnosed hypertension, renal dysfunction, diabetes can all contribute. And then we mustn't forget about things like genetic conditions like hypertrophic cardiomyopathy, alcoholic cardiomyopathy, and cardio-oncology. I don't know why that's gone big there, but we are seeing more of that because we're seeing more and more drugs for heart failure, which can lead, for cancer that can lead to heart failure. Herceptin was the commonest. So I'm going to go on and talk about what is heart failure, what are the subcategories. So it's a complex clinical syndrome resulting from either a structural or functional cardiac disorder. So structural may mean damage to the heart caused by a myocardial infarction. Functional may be a fast heart rate with atrial fibrillation that isn't well enough controlled that can lead to a tachycardiomyopathy. And that disorder impairs the ability of the heart to function as a pump. And I want us to get this concept of left ventricular ejection fraction nailed in our heads, because this is how we now classify heart failure. And you need to remember it's a percentage. The ejection fraction is a percentage. It's not the milliliters of blood that the left ventricle is pumping out with each contraction. And we use a formula where the stroke volume, which is the amount of blood pumped out of the left ventricle or the right ventricle, if we're talking about the heart, divided by the end diastolic volume. So the amount of blood that's in there after filling of the heart or diastole. So systole is the pumping of the heart, diastole is the filling of the heart times 100. And normal ejection fraction is anywhere between 50 to 70% because not all the blood will be pumped out of the heart. So heart failure with reduced ejection fraction is 40% or less. Mildly reduced is 41 to 49%, and preserved ejection fraction is 50% or over. Now, that can be a difficult concept to gather, and I just want you to initially just look at the shape of these hearts. So a patient with reduced ejection fraction often has stretched dilated chambers, increased diastolic volume, so there's more blood in the heart because it's often baggy and fills up. And that left ventricle, because it's baggy, it's not contracting well, fails to eject blood, and that leads to a lowering of the ejection fraction. Patients with preserved ejection fraction have stiffened or thickened chambers, diastolic dysfunction and ventricular filling with an increased pressure. And if you look at the volume in the left to the right, you'll see that there's far less blood in that patient with diastolic impairment. So even if the ejection fraction is higher, then probably less blood is pumping out of the heart. And I want to show you that very quickly in figures. So if we look at a normal heart, the end diastolic volume, so the volume in the left ventricle in a 70 kilogram man is around 142 mils. And the end systolic volume is 47 mils. So let's say 95 mils is pumped out. And if you use that formula, that means a normal ejection fraction of 67%. Now, a patient with HFrEF may actually have a higher end diastolic volume, so more blood in the left ventricle. And if only 50 mils are pumped out, then you have 100 mils left. and the ejection fraction is then 33%. And if you then look at the preserved ejection fraction, because the volume is less, a bigger proportion is being pumped out. That's 53%, but actually that's only just a little bit more than the patient with reduced ejection fraction if you compare them. And I want you to try and remember that, because many people don't understand how you can have heart failure with a preserved ejection fraction. Now, diagnosis, it's relatively easy in reduced and mildly reduced, because it's just symptoms and signs and ejection fraction. How these patients usually get there is with raised NT-proBNP, and we'll come back to that. Preserved ejection fraction is more complicated to diagnose, but I sometimes think we make it more complicated than it is. So what we need with HFpEF is symptoms and signs, an echocardiogram that shows preserved ejection fraction, and then we need either evidence of structural abnormality, so left ventricular hypertrophy or left atrial assessment, and or functional abnormality, that's evidence of diastolic dysfunction. And usually these patients also have raised NT-proBNP, and that's how they've got in to be assessed. I'm not going to go through this in great detail, but you can see from the European Society of Cardiology guidelines, they give us measurements of the left ventricular mass index, the left atrial volume index, and then they go on to also talk about diastolic impairment in terms of the E over E prime, which is a difficult concept to gather unless you're an echocardiographer or a heart failure cardiologist. But very simply, the higher the E over E prime, the more diastolic impairment and basically slow flow across the mitral valve that we'll see. So 9 or greater average, along with symptoms and signs, along with raised NT-proBNP, to me is HFpEF. The NT-proBNP levels, which we'll discuss later, are different in Europe than they are in the UK, and they're different for sinus rhythm and for atrial fibrillation. Now, I'm going to quickly talk about coding. It's vital that we code patients, that we get them coded in GP systems, and then hopefully they will be reviewed every year and managed. So we need an umbrella code, heart failure, and I said you'll get these slides. We then need evidence of an echo that shows left ventricular systolic dysfunction. So I should have said earlier that reduced and mildly reduced are what we have as our old LVSD categories, or left ventricular diastolic dysfunction. So we need to code the echo, and then I would advise that we subcategorize, code these patients so that we then know what management they need. So that's the diagnosis basis and the coding, and we'll come back to investigations. I really like the ESC guidelines because they also talk about prevention, which we don't see much of in the NICE guidelines. And this is where, you know, Jack talked about cardiovascular disease prevention. We in primary care should be diagnosing hypertension, diagnosing hyperlipidemias, managing patients with diabetes with drugs like SGLT2s that reduce the development of heart failure, and if they have it, improve it. So we should be aggressively managing hypertension, lipid disorders, and also don't forget lifestyle, stopping smoking, reducing alcohol intake, exercise, reducing cigarette smoking, etc. We are well placed in primary care to do this. So I always talk about prevention of heart failure too. Diagnosing heart failure, I'm just going to quickly mention a real patient that I looked after a few years ago now. She was 71 years old, worked in the old Rothmans factory where they used to give people free cigarettes until about 1996. She's previously had a non-STEMI with stents, a COPD and emphysema, hyperlipidemia and hypertension. So she's on these array of drugs. Over a few months, she was getting breathlessness. GP took a history. She gets short of breath when she lies flat in bed, peripheral edema, examined her, and, you can see the examination there. So what tests should we be using? Well, I'll come back to these in detail, and I probably should have moved this, sorry, to the end of the investigation bit, but we've done her routine bloods, all satisfactory. NT-proBNP is significantly raised, and Darlington are pretty good at seeing patients within a fortnight, unlike many of the places in the country. And she had an abnormal ECG, which we'll come back to later. So just briefly, the pathophysiology. We've talked about these conditions that cause it. You get often left ventricular injury, pathological remodeling. You also get this neurohormonal activation with vasoconstriction, endothelial dysfunction, renal sodium retention. That leads to symptoms and heart failure. And patients can die of pump failure or in arrhythmia. We can look at this in more detail. You've got the natriuretic peptide system, which is a beneficial system. So natriuretic peptides can reduce blood pressure, sympathetic tone, aldosterone levels, lead to salt and water excretion and antifibrotic activities, whereas the renin-angiotensin system is detrimental. It causes vasoconstriction, and that's why we want to use the drugs that prevent this. So what NICE tells us to do is take a detailed history, perform a clinical examination. That should include natriuretic peptides, ECG and bloods that you see there. If the NT-proBNP is less than 400, heart failure is unlikely, and we should think of another diagnosis. If it's over 2,000, refer urgently within a fortnight. 400 to 2,000, refer urgently within 6 weeks. And part of my PhD was looking at natriuretic peptides. So proBNP sits within the left ventricle, and if the wall comes under stress, it's cleaved to the inactive moiety, which is NT-proBNP, and the active moiety, which is BNP. The BNP leads to suppression of the renin-angiotensin system, decreased peripheral vascular resistance, and increased excretion of sodium. And we can measure both of these in the blood. NT-proBNP is raised in diastolic, systolic dysfunction, right ventricular dysfunction, and is the recommended test because it's more stable at room temperature, and there are more studies that look at that. But we also need to remember that natriuretic peptides are raised not just by heart failure, but other cardiac and non-cardiac causes. So please don't tell your patient, oh, you've got symptoms and signs, you've got raised NT-proBNP, you've got heart failure, because they may not. They may have other things like left ventricular hypertrophy, valvular disease, pulmonary hypertension, etc., or looking to the right, things like paraneoplastic syndromes, cancer, anemias, etc., all of which we can raise NT-proBNP. But what raised NT-proBNP means is something is going on, and heart failure is one of those, and we need to look into it. Now, some areas use age-related cutoffs, because I was involved with Per Hildebrand from Denmark, Paul Collinson from London, and 10 other centres across the world, New Zealand through to the States, where we looked at the raw data from for NT-proBNP for patients going through a heart failure diagnostic process. And we found that the only thing that made a significant difference was age. So age-related cutoffs are often used by some labs in the north, some services in the Northeast, including Stockton, I think, still uses those. And I've always been disappointed that NICE hasn't looked at this, because there are studies that show by using age-related cutoffs, you may actually reduce the requirement for echocardiography. We also need to do an ECG, in my opinion, on everyone, because it can give us information. Chest X-ray in particular, if they have a cough or smokers, and all the other tests, because severe anemia can cause shortness of breath, peripheral edema, albuminuria on the liver function, etc. So we need to be checking all these other things. If we look at this particular patient, Mrs. T, her ECG actually showed left bundle branch block. Remember, she'd also had a previous MI. So ECG in itself doesn't diagnose heart failure. There's no specific findings on an ECG that says heart failure, but any abnormal ECG, ischemia, atrial fibrillation, left bundle, right bundle branch block can all make heart failure more likely. But we've also got to remember that normal ECG doesn't mean you haven't got heart failure. About 25% of MIs, especially in diabetics, are asymptomatic, and we may find that as we're assessing the patient. Chest X-ray can be useful. This patient has got a huge heart, but cardiomegaly itself makes heart failure unlikely, but is not a diagnosis. So this patient definitely needs assessment. Now, what about case finding? I think that's vitally important. So we see patients with suspected heart failure who may come in with symptoms and signs, but we're often castigated in primary care because one study showed that 80% of diagnoses happen in hospital. So we need to be aware of symptoms and signs, but we also need to ask questions. And many years ago, I set up in my own practice and across several Darlington practices that all patients coming to long-term conditions clinics, and we see 90% of them per year, we asked about shortness of breath, peripheral edema, orthopnea, PND. We had a template that we developed, and if they had any of these symptoms and signs, whether they're diabetic or hypertensive or whatever, we had a low threshold for NT-proBNP. And we were able to show, and this is from Public Health England Northeast in 2018, we were able to show that in Darlington, it was a CCG then, had the highest prevalence of heart failure in the region, but the lowest rate of admissions, significantly lower than England as a whole, and had one of the lowest mortality rates for heart failure in the region. And we started this work in 2014. So you'll see at the bottom there, we're the lowest, and it dropped to actually less than 100 the year after when the British Heart Foundation used our data, and Darlington model is in the British Heart Foundation blueprint for heart failure. We did a lot of work around case finding. We used searches, we used Oberoi searches and a conflict of interest. I am now their medical director, but we were able to show that the latest prevalence, so at the time, the PCN prevalence in England data was 1.55. When we started doing the work, it was 1.61. And after we did disease register validation, we were able to show it went up to 1.97%, with 255 patients across Darlington who weren't on registers. We then looked at some data across Tees Valley, so looking at prevalence, LVSD percentage, admission data, deprivation data, and we got funding from NHS England to run the Oberoi work, or the validation and management optimization work, in some of the lower performing PCNs. So it's valuable to use this sort of data to then target where you should do the work. And we've presented the heart failure case study back to NHS England, and it's on the Futures website. But in the 7 PCNs that we looked at, we increased overall prevalence with increased numbers of patients with HFrEF, mildly reduced, and HFpEF on registers. But we also then went on to show that we reduced the numbers on no therapy and significantly increased the numbers, especially on the 2 pillars of care, and then ultimately the 4 pillars of care, which are ACE, ARB or ARNI, beta blocker, MRA or SGLT2 inhibitor. So I'm just going to briefly mention diagnosis, management, because I think we will come back to look at this in detail. So when I graduated in 1982, there were virtually no drugs for heart failure. If I'd said use a beta blocker, I would have failed my finals. Things have improved. There is much evidence that multiple therapies reduce morbidity, reduce admissions, improve quality of life, and reduce mortality. It should be about that, not just symptom control. We should, is that appearing or not?
Yes, it is, yeah.
Can you see the 4 classes on it?
No.
I can't see it either. Yeah, I don't know why that, but basically we should use NYHA classification. I don't know why it's not showing. When we assess patients, class 1 is no symptoms, class 2 is mild symptoms, class 3 is moderate symptoms, and class 4 is symptoms at rest. And all patients with symptoms should have their treatment optimized in primary care. And what that means for HFrEF is going on to an ACE or an ARNI, ARB rarely, a licensed beta blocker, an MRA, and an SGLT2. We've not got time to talk about this in detail. We've not got time to talk about devices, but we can maybe talk about that in future webinars. We should think about the 4 pillars of care. And I know you think I can count, but there are 5 boxes, but actually ACE/ARB is a neprilysin inhibitor, which is Entresto or sacubitril valsartan, come under 1 pillar, beta blocker, MRA, and SGLT2. For mildly reduced, if they are symptomatic, this is ESC guidelines, we should consider all those 4 drugs as well. Just a plea for this American term, improved ejection fraction. If someone has HFrEF and the ejection fraction improves to over 40%, with some caveats, if it's straight after cardiac surgery, if it's because of uncontrolled atrial fibrillation, then we may not code the patient. But if they've been coded as this, we should never change the coding. And we should never stop the drugs, even if the ejection fraction goes over 40%, because they will then deteriorate. And trials like TRADE-HF have shown us that. Finally, in terms of treatment, HFpEF. So in 2023, the American College of Cardiology suggested that everyone with HFpEF with a class 2A indication should go on an SGLT2 inhibitor. It was class 2 because at that time only empagliflozin study had been published. Now we have dapagliflozin. So with 2 randomized controlled trials, it's now a class 1 indication. And other things like loop diuretics, MRAs, etc., we may consider, but only with a heart failure team. So I'm just going to finish off with my last two slides. And I want you to all download these. Ideally, every PCN should be taking these steps to identify and manage heart failure. So prevention, making every contact count, checking blood pressure, pulse, weight, NHS health checks, predicting heart failure, asking questions of patients with long-term conditions, and having a low threshold to do NT-proBNP. If patients present with symptoms, don't dismiss them. Test with NT-proBNP, detect with echocardiography, either in a specialist clinic or by open access, then refer on if they've got heart failure, code it properly, and then in future webinars, we can talk about protect, perfect, and even de-escalate. So these patients, when they reach severe frailty, end of life, we need to think about stopping some drugs and deactivating their devices. So I hope you've got some take-home messages. Prevention heart failure with diagnosing and managing the common conditions we see, like hypertension, lipid disorders, diabetes AF, CKD, ischemic heart disease, predict, suspect, and test, beat heart failure, Pumping Marvelous, or a patient charity got great stuff on there, so look at that, accurately diagnosing and coding, and then we should go on to offer the appropriate treatments, regularly review, use specialist heart failure nurses. They're amazing. They can titrate drugs, see patients who have decompensated, keep them out of hospital or plug them into clinics. And if patients deteriorate, think about, has their condition worsened? Do they now have HFrEF instead of mildly reduced or HFpEF, and use local data? So thank you very much. I've galloped through that. I'm not sure if there are many questions, Mark, but I hope you all found that useful.
Thank you, Professor Ahmed. That was fantastic, and a really great explanation for me, who is a non-clinical individual with a physio background. A great explanation of HFrEF and HFpEF. Simple, clear, but fantastic, and also great case studies to see the work that you've been doing in Darlington and how that's changed over the years and improved. And then the case study around Mrs. T was really helpful as well, just to bring those messages home.
Thank you.
So thank you both to yourself and Jack. I have been keeping an eye on the chat. There aren't very many questions, which means that both presentations must be very clear and concise and fantastic information. I do have a couple of questions, and we've got a couple of questions that I've written down. So Ahmed, the first question to yourself, you mentioned at the beginning of the presentation around the underreporting of heart failure. Do you know what the kind of estimated national prevalence for heart failure should be? Is there any kind of data out there that kind of gives a specific kind of percentage of this is where it is currently, but this is where we think the estimated prevalence should be?
Yeah. Absolutely. So it's always difficult to predict because you have to model things. So the only study that gave us some insight into that was by Richard Hobbs and his colleagues in Birmingham a few years ago, where they screened patients within many practices across Birmingham and the wider area. And that estimated that the prevalence of LVSD should probably be around 1.4%, and the prevalence of heart failure should be around 1.8%. Now, it's really difficult to predict. I mean, I can tell you that when I was at Carmel, our prevalence was 3.2% because we were diagnosing and coding HFpEF, I guess mainly because I'm a specialist and that's what I do. So I think especially HFpEF, has been underdiagnosed, undiagnosed, because often we've had no treatment for it. And I've even heard cardiologists, Yasaf, I know you're on the call, not you, say, well, you know, what do we do even if we diagnose it? Let GPs look after it. It's a bloody difficult condition to look after, and they yo-yo in and out of hospital. So I think that it's definitely underdiagnosed, and there will be great variation because of demographics. So we should have a highish prevalence in the Northeast because not many of our elderly move out of the area, and we have a high coronary artery disease burden.
Thanks, Professor Ahmet. And then just a question for yourself, Jack. I thought the data was really interesting. One of the questions I had around the data is that shared with kind of individuals kind of within the local delivery teams and the PCN directors? And how do you think that data will help inform change in practice?
Yeah, it's a good point, Mark. We've only started to look at that data recently, so at the moment, I don't think from us anyway that it's being shared, but I do know local delivery teams obviously have their own kind of plans and work plans and might have already been looking at some of the data locally. But we can definitely, as we work through ICB related stuff as well, we are going to build closer relationships with local delivery teams and what have you to kind of understand the data and inform future work. What was the second part of the question again? Sorry, Mark. I've just
it was how it informs a change in practice, really. Yeah. So yeah, you were getting on to that.
Yeah. So obviously, as I mentioned at the kind of start of those presentations, it was the ICB is keen to identify obviously the variation, invest in greatest areas of need. So it will be ultimately looking at where we can better case find and where we do have higher cases of heart failure, how we then appropriately manage those as well. I think working closely with the heart failure teams through the heart failure group that I said we've established will be really important to understand in practice how we do that, because we can look at the data, but it doesn't give us a full picture. We really need to, work with the teams, speak with the teams to understand what the challenge is in practice ultimately. So I think we're just at the kind of start of that now. We've just recently started that group last month it was. So it'll be interesting to see how it pans out, because we've already started to get some ideas and challenges, what we've heard. So yeah.
Absolutely. So could I just come in there, Mark? Yeah, and yes. Interestingly, NEQOS have got really good data. So I was going to contact you, Jack and Joe. I've just got data for heart failure prevalence across all the PCNs in the Northeast and North Cumbria while I was researching this. But it's interesting, and I think we need to build in some of the elements that I talked about there. What was interesting with the diuretic slide is, so these are already patients who have heart failure. And, the fact that 50% in one area are still on a diuretic suggests to me that it's very possible that they are not getting the 4 pillars of care. Because if they're on an ACE/ARB ARNI, and especially if they're on an MRA or an SGLT2, often you can get them off diuretics because 2 of those drugs, in fact, all 3 probably have some diuretic activity, some more than others. So you could start to look at, is the high diuretic use in Sunderland because the patients aren't being appropriately treated with the other drugs. But what is even more interesting, and we've just published a study with Hull University and Castle Hill Medical School, is that the patients who are on diuretics in the community that have not been considered for NT-proBNP and for a diagnosis. So that's one of the searches we can use to actually then go into notes and say, actually, could this patient have heart failure? Do a test and then get them an echo. So I think there's 2 elements of that, and I find that quite interesting. So
thank you. Thank you, Ahmed. So there is one more question in the chat, but Ahmed, it's a clinical question and I might get you to respond if that's okay via the chat function. I do want to try and stick to time because I know that we're at 1 minute past 1.
Yeah.
So just a couple of
yeah, absolutely. I see it's from my old friend and groupie, Anthony Kutajar, who follows me around on meetings. And he's certainly not in the northeast and North Cumbria, so I don't know where he's come from. What do you advise with SGLT2s and renal failure with EGFR below 30? Well, I use SGLT2s down to 20. So I think they're still beneficial. Although the SPC, as you rightly say, Anthony, says down to 25, I think that I would still use them, but if you have concerns, always ask a cardiologist or a nephrologist for advice and guidance. So it's a very interesting question. And maybe when we come to do the management bit, I always talk about problem solving, including what we do with hyperkalemia or deteriorating renal function in terms of the RASI drugs, ACE/ARB ARNIs, the MRAs, and the SGLT2s. So it's a very important point, Anthony, and we'll probably discuss that in future meetings.
Excellent. Thank you. So just closing remarks from me. I want to thank Professor Ahmed Foot and Jack Lyon for their presentations today. Jack mentioned the heart failure group across Northeast North Cumbria that's been recently launched. If that's an interest to you, Jack, would you be able to put your email address in the chat, and then people can sign up and be invited to the next meeting? And we would still appreciate any ideas for future topics. We'll probably go on to focus on the management and treatment of heart failure, as Professor Ahmed has mentioned. But if you've got any other future topics, if you want to email Joe Chidanyika, and Joe will put his email address in the chat as well. And finally, just to thank everyone for giving up their lunchtime to come and join us. Really great to see so many people on the call, and enjoy the rest of your day, everyone. Thank you.
Thank you very much. Bye, everyone.
Thanks, everyone.